All right, good afternoon, everyone, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter for today, Dr. Jamison Montes de Oca, who will be presenting on a very relevant topic as we head into summer, tick-borne illness. At this time, I'm going to stop sharing my screen and turn the presentation over to Jamison.
Great, thank you for the introduction. And if everyone can see my screen, I'll go ahead and get started. So my topic today is going to be Lyme disease and other exotic encounters. And I'm a clinical pharmacist in infectious diseases downtown at Norton Hospital. Our objectives are going to review the epidemiology, surveillance, and geographic differences between common tick-borne illnesses, as well as review some treatments for common bacterial tick-borne illnesses. Now, there's a bunch out there, and unfortunately, due to time's sake, we will not be hitting them all. But we'll talk about a few of them today, and the ones that we're going to focusing on today are going to be listed here. And here's just a brief outline. And this next slide is just kind of a summary slide for everyone, especially for those that are reviewing this on YouTube, just kind of have a lot of the information in terms of the microbiology all in one place. So we'll be focusing on Lyme disease, which is borreliosis, and then the rickettsial diseases, so Rocky Mountain spotted fever, or Leosis, as well as Anaplasmosis. As I mentioned, there's plenty of other ones. There's other bacterial ones that are just less common. There's some parasitic ones, as well as a bunch of viral ones, which I won't be talking about those today just because they're a little bit different in their treatments and management. And I wanted to hit the ones that are most that are going to really be most pertinent to our practice here in Kentucky. And there's a couple that are coming to my mind that are not listed here, that some viewers in the audience might also be wondering about. And those two are tularemia and babesiosis. Now, tularemia is definitely in Kentucky. Babesiosis is not so much, it's more so in the New England area. But in my opinion, tularemia, we just don't have enough time to hit it on, give it the time it deserves. And it also might, in my mind, fit more with the oddball infections, kind of like more animal vectors. And for those who don't know, tularemia is transmitted by rabbits, as well as ticks. So I kind of threw a little reference to the Monty Python rabbit. I can never remember its name or pronounce it at all, but tularemia is very cool. Can cause some very fatal meningitis pictures. And just to give everyone a little taste of it, but I would like to do maybe a presentation later in the future about it. But kind of just here's a case report and review of the literature of some of the wild treatments that have kind of gone for tularemia. They kind of just span all over the place, from blood transfusions to survivors to intrathecal horse serum to all the way to chloramphenicol and now to doxycycline, which we use today. Now, for surveillance data, we're going to take a peek at the total cases that we've seen in the past few years from the CDC. This is available at the website below. It's a very fantastic website. So this is just one of many views that we'll be looking at today. And this is kind of just showcasing data from 2016 to 2019 of tick-borne diseases that we've seen in the United States. These two figures, the graph and the table, they're the same information, just displayed in two different ways. If some people like more visual approach, while others prefer maybe the more numerical amount. But you'll see that Lyme disease is this teal color. It might be hard to see on the monitor depending on how you have your light settings, but Lyme disease is this large, like dark teal color. It's really the predominant tick-borne illness that we see in the United States, followed by Anaplasmosis, and then the spotted fever, Rocky Mountain spotted fever, and then some more of the Ehrlichia, tularemia, and then some kind of like hard to document ehrlichioses, which can kind of be grouped over with this Anaplasmosis, be grouped with the ehrlichiosis, which is this dark blue. But you kind of see we're about the same, maybe a little bit more back in 2017, and we just don't have data yet available from the CDC for 2020 through 2023 for total tick-borne diseases. But we do have some more geographical data we can look at. So this is kind of a more than 1,000-eye view of the United States and kind of the prevalence of tick-borne disease. I kind of color-coded it because it's a little bit hard to see, but all this brown is kind of this Rocky Mountain spotted fever, and then this that dark teal, same colors that we saw previously, is this Lyme disease. Ehrlichiosis, Anaplasmosis, you can kind of see the blues and purples there. Babesiosis is a little up here in the New England area, and tularemia is actually pretty hard to spot just because there's fewer cases, and it kind of gets mixed in with this like burnt orange color. All of this is Rocky Mountain spotted fever, just is more intense brown because there just is a lot more cases that kind of just makes it hard for the eye to see. But we'll take a little zoom and talk a little bit more about these. But for now, we're going to ignore the western side of the United States, kind of focus in on the Appalachian New England, since that's what's closer to us. So we kind of see a little bit more separation of the colors and kind of still seeing what I just discussed. But Wisconsin, Minnesota is kind of, we're going to see a little bit more anaplasmosis, as well as ehrlichiosis, kind of see a little blue tinge in there, as well as Lyme that's widespread. So Lyme loves the New England area, babesiosis loves the New England area. You don't really see babesiosis elsewhere. Now we'll talk a little bit about Kentucky and babesiosis, but I won't be getting it into much detail. But one more view going into our neighborhood. So as you can see in Kentucky, again, from the same website, we're just looking at like a very close-up image. We're looking at Rocky Mountain spotted fever as the predominant tick-borne illness. So this is going to be all this burnt orange brown color. And if you look closer, you can see some other colors in there. So there are little blues here. Those are going to be ehrlichiosis. And if you look just over the border of Indiana, you'll see some anaplasmosis and then Lyme over here. If you look really close, you can see some other ones, but we'll kind of remove the Rocky Mountain spotted fever just to like get a better understanding of some of the rare ones. So remove the Rocky Mountain spotted fever, then we can see a lot more of the more discrete colors. So actually a couple tularemia cases here, as well as up here as well. And there's actually I found one reported case of babesiosis in Kentucky. You won't be able to see it because it was a co-infection with ehrlichiosis, so the darker color of the ehrlichiosis kind of takes over, but it was over here in northern Kentucky. And it was the only case of babesiosis in Kentucky that was reported to the CDC and reported to us from 2016 to 2019. But as you can see, we have a lot of Rocky Mountain spotted fever, ehrlichiosis, anaplasmosis, and a couple of cases of tularemia, and maybe on a very rare event of babesiosis. Now, kind of comparing year by year. So previously we were looking at 2016 to 2019 data, and that's just total cases that we had. We do have some data for 2023, or up to 2023, excuse me. But this is more so emergency department visits for tick bites by month. So we can kind of see the temporal aspect of when patients present to the hospital. And you'll see it's a big peak in the summer, which obviously makes sense. We're all getting out of the seasonal depression and trying to get some sun. So we're all going to be out and about. And this, we're really going to see a lot more tick bites and presentations. And we'll see again in the fall. And this is, from what I was reading, more explained by the life cycles of the ticks. And they kind of just they have like I don't know what to call it, maybe like not, I guess it's the title, but like an uptick in the frequency of infections that they can cause in the latter months of the fall. But you'll do see it's kind of like we do have a kind of a strict line of two peaks. So we have this inner peak and this outer peak. So we see in the 2017 to 2019 era a lot more cases, followed by the 2020 through 2023 era, a lot fewer cases, but we are on the rise a little bit. I don't know what happened in 2019 that could have possibly caused everyone to stay inside, but we're kind of seeing our numbers grow and grow as more people become comfortable going back outside and kind of getting one with nature. So I expect in 2024, this number to keep going up, and we'll probably reach back to our pre-19 numbers. So part two, starting to talk about Lyme disease. But first, we do need to address the elephant in the room, and that is everyone's favorite antibiotic. So I consulted the Twitter sphere in terms of asking the question, what's your favorite antibiotic? And of course, the answer is doxycycline. There is no other answer. So you can look around here, everyone's going to say doxycycline. It's the most fantastic drug. It cures everything, treats everything. And you're not really an infectious diseases pharmacist if you don't believe that doxycycline is the supreme antibiotic. It really just its spectrum of activity just transcends all of other antibiotics. If you look here, if you have a poor taste in men, it'll cure it. Even your barber likes it. So maybe I should be asking my barber the next time I go. And maybe I need to change it up if he does not like doxycycline. So kind of a brief slide on doxycycline itself. Spectrum kind of briefly mentioned. It just treats almost everything. Not everything, but almost everything. Q fever, STIs, various gram-positive, gram-negative bacteria, as well as atypical bacteria. It's just a broad spectrum antibiotic, very widely available, and a pretty not terrible toxicity spectrum, but we'll talk a little bit into that later. And what's great about it, why it's so pertinent to our discussion today, is its rickettsial activity is very, very potent. It's the most active of all the tetracyclines, and as we'll discuss later, it's really our first-line agent for most of these infections. In terms of adverse events, which I briefly mentioned, just a few things about, since patients who are going to get these tick-borne diseases are going to be in the outside. Photosensitivity, esophagitis, this is really with the PO version. and just kind of taking it right before bed and maybe not taking it with water. And then you just wake up and just feel absolutely dreadful just because it causes almost an ulcer in your throat. And then lastly, teeth staining and enamel hypoplasia, which we'll talk about a little bit more. This is kind of a little area of not necessarily controversy, but maybe controversy in the past. But when we talk about the treatment and management of special populations, we'll be referring back to this adverse event. And what's great about doxycycline as well is when you give it for these patients with these rickettsial infections, you really do have a rapid response in terms of improvement. Anywhere from like 24 to 72 hours, maybe longer than that if they are critically ill or immunocompromised. Immunocompromised is a very big risk factor for developing a very severe tick-borne illness. That's just because of the impaired immune system, of course. So for our first tick-borne illness, Lyme disease or Leosis, the transmission is going to be through the black-legged tick. This is given for its name because it has black legs. But incubation time, very widely variable, anywhere from 3 to 30 days, with a median around a week. It really has a very variable. But as you can see, I kept a little graph up here to give us a reminder of what areas are most impacted by all of these diseases that we'll be talking about. You'll see that we have a little bit in Kentucky, but it's predominantly more in the New England and northern Wisconsin, Minnesota regions. And when it comes to Lyme disease, the presentation that we're really going to run into is kind of this multi-stage approach. So there's going to be the inciting event, which is going to be the tick bite. And you're going to have this rash. And it's a very unique rash called the erythema migrans, or also known as EM. And sometimes Lyme disease is referred to as erythema migrans or the treatment of methylroid migrans, as well as some fever and flu-like symptoms. This can rapidly, or not rapidly progress, but over time of like a month or a week to a month can progress to this disseminated infection. And this is going to be where the more critical disease kind of flourishes. You're going to have these dermatologic, neurologic, cardiac manifestations, as well as some ophthalmic manifestations. In terms of dermatologic, so we have that EM rash. You're also possibly going to have this rash disseminate to other parts of the body. It can also go to the trunks, the hands, the feet, and also can become a little bit different in appearance. I have two pictures here of the EM rash. So this first one, where my cruiser is kind of highlighting, is the traditional like early rash, and then it can kind of progress to what's called this like bullseye rash, which is still in the early stages, maybe almost early middle. But that's indicative of EM. And what can happen, I don't have extra pictures, but there's so many different rash manifestations that this can turn into. It can become necrotic. As I mentioned, it can go in the trunk and become a little bit more widespread, become vesicular. And just there's a lot of different manifestations. If you review the reference number 1 here, tick-borne diseases, the reference manual has great pictures of very different manifestations and various at various stages of EM as in the disseminated reaction. So it's a good view. But in terms of neurologic manifestations, we can develop a meningitis, facial palsy, ataxia. Any one of these neurologic conditions can, general prevalence around 15% of people who have this disseminated infection. It can also impact the heart, can get these AV nodal blocks, also these pancarditis, pericarditis, a little bit more rare, probably around 5% of cases that reach this point develop those manifestations, as well as musculoskeletal manifestations, which really are seen in the form of like joint pain, myositis, arthritis. And this is actually pretty common. These are around 60%. And that's actually kind of more related to the late infection, which is like these, once this patient has been treated appropriately, a good chunk of the patients actually start developing this like late infection where they have these rheumatological manifestations that don't really go away despite like initial like appropriate treatment, which we'll see on the next few slides. But complications that can arise from this co-infection with babesiosis and anaplasmosis, as they're both possibly transmitted through the same tick, as well as post-Lyme syndrome, which is related to rheumatologic manifestations. And this is kind of an area of controversy. It's been under a little bit of fire previously. And the IDSA actually, I guess I should speak a little bit. Post-Lyme syndrome is related to these like rheumatologic manifestations, but it's more so these long-standing fatigue, generalized subjective symptoms of tiredness, pain, and they really like have a large overlap with a lot of comorbidities. And so it's hard to like pinpoint, is this actually just normal comorbidities, or is this something related to the Lyme disease that the patient had. Not everyone develops this, but it is fairly common, months to years down the road of having a successful treatment of Lyme disease. And the IDSA does comment on this, as well as the CDC does comment on this on the management of post-Lyme syndrome. And they do not recommend additional antibiotics for this just because there is not enough evidence to support. And there have been studies that have looked at treating patients with additional courses of antibiotics and found no difference. So currently, as data stands, the IDSA CDC recognize post-Lyme syndrome as a possible consequence of Lyme disease, but don't recommend additional antibiotics towards it. And for the treatment of Lyme disease, we do have a few options. So for treatment of Lyme disease, doxycycline, amoxicillin, ceftriaxone are all appropriate options. These are all PO options. Doxycycline also comes in an IV available. I have the durations listed here. There are some IV options available. So commonly ceftriaxone will be your cephalosporin that you could use that will have activity. Sometimes that's used for more critical cases that might have a meningitis or a neurologic manifestation or cardiovascular manifestation. And as well as doxycycline can be used there. The dosing becomes a little bit different. Lyme disease with Lyme carditis, I should say, sometimes be treated with a little bit higher doses of doxycycline or ceftriaxone, but any one of these three are appropriate. The caveat is if you are worried of other tick-borne illnesses, if you were to use amoxicillin, ceftriaxone, ceftriaxone, you're actually going to lack activity against some of those other ones. I mentioned on that previous slide that you have to worry about co-infections with babesiosis, anaplasmosis. Now, none of these really, sorry, I apologize. For anaplasmosis, amoxicillin, ceftriaxone don't cover it. So if you were to choose ceftriaxone, amoxicillin, you will be missing that pathogen. And then babesiosis is its own beast in itself. It's a parasitic organism. Its treatment is a little bit different. But again, as I mentioned earlier, it's a little bit, we just won't have enough time to talk about babesiosis. Now for part 3, our rickettsial diseases. So this is going to be our Rocky Mountain spotted fever, our Leosis, and our Anaplasmosis. So for Rocky Mountain spotted fever, the primary organism is R. rickettsia. Now I mentioned earlier there's a bunch of different organisms. This is just the most common in our area. But if you go internationally or anywhere in the United States, honestly, there's going to be so many different rickettsial organisms. There's Australis, Hornii, Honii. There's so many different pathogens, but for the sake of this presentation, we'll be focusing on the most common US one that we'll see in our everyday practice. Transmission here is going to be the American dog tick, which is going to be typically in the eastern, central, and western United States. For the brown dog tick, this is going to be more so in the southwestern United States, so somewhere around in the Arizona area, as well as there's the last one, least common, is the Rocky Mountain wood tick, which, as its name might imply, the Rocky Mountain area. But generally speaking, for our purposes of management of Rocky Mountain spotted fever, we're most likely going to run into the American dog tick. That's going to be in our general neighborhood. Incubation is also going to be very similar to the previous, but a little bit more narrow. So we do have a medium of 7 days, similar to Lyme disease, but we're also going to have a little bit, our lower and upper extremes are kind of on the shorter spectrum. Instead of up to 4 weeks, we're going to be looking at 2 weeks. Presentation, very similar, fever, headache, general flu-like symptoms. Some of the differences that start to arise with Rocky Mountain spotted fever become the rash. So in that Lyme disease has that EM rash. This is going to be more of a maculopapular rash. And not always, but most of the time it'll be there. So 90% of the time it'll appear in the early stages, if it appears at all. But then sometimes as you get more progressive diseases, you'll get this petechial rash, which is about 45%. And this is more of the late infection. That kind of just as the infection develops will progress into severity of illness. Petechial rashes are associated with more critical illness. And our complications here are a little bit similar, but to Lyme disease, but a little bit more narrow. So we do have this meningoencephalitis, similar to how we had a meningitis aspect in Lyme disease, or those neurologic manifestations, as well as multi-organ failure. So a lot of these illnesses are very deadly, especially if you do not start treatment right away. So especially these next 3, these rickettsial infections, there's a high risk of mortality if antibiotics are not started early, or delays in antibiotics and really cause complications in the illness as well as death. For our next one, Leosis, this is a transmission through the American Lone Star tick. And as we mentioned earlier, we definitely have this one in our neighborhood. Again, our incubation is about 9 days. Again, similar to a Rocky Mountain spotted fever and a Lyme disease previously. Presentation, almost super similar to Rocky Mountain spotted fever. Major differences here are with rash, and we'll see this trend as we go into anaplasmosis, but our rash incidence actually goes down with ehrlichiosis. It will be down to 36% or so, as well as it'll be more macular. Now, you can still have the petechial aspects of it as it progresses to more complicated or critical illness, but generally speaking, ehrlichiosis will have a little bit less frequency in terms of developing a rash. And it is a little bit more common in children. And I do note that for ehrlichiosis, I have Ehrlichia chafensis. There are other ones, Owingii, and as well as Mirus. I have Mirus not shown here, but or I guess it is down here on the complications, but the black leg tick, or the one that causes Lyme disease as well as anaplasmosis, can also transmit Ehrlichia mirus, but it is a very low frequency of infection. So most of the time that we're going to run into ehrlichiosis, it's more often going to be this organism listed here. And it's also all of the reported mortality events with ehrlichiosis do come from this organism. So it's another reason that we're focusing on it, as it might potentially cause more severe infections. Now, similar to Rocky Mountain spotted fever, we're going to have a meningioencephalitis as a complication, multi-organ failure, co-infection with our Lyme disease if it is that Mirus organism. And specifically for ehrlichiosis, you can develop a HLH, which is a very life-threatening autoimmune disease, essentially one of those cytokine storm syndromes, which does require prompt identification. And depending on how severe it is, could warrant a variety of therapies. We won't be discussing at length some of these, but some of the managements of HLH include a high dose steroids, and in some of the very, very severe cases, you can actually give chemotherapy agents such as etoposide. And for our last tick-borne illness that we'll be discussing will be anaplasmosis. So transmission, same as the Lyme disease organism, so the black-legged tick. Incubation, about the same as the previous, and very similarly in terms of the presentation, almost identical in terms of ehrlichiosis. The one big difference is the rash, as I alluded to previously. Actually pretty uncommon. Less than 10% of the patients develop a rash, but the symptoms otherwise are very reflective of ehrlichiosis, and very much in terms of the lab findings you'll see, as we'll discuss on the next slide. But labs are going to be very similar to ehrlichiosis. And again, we'll see complications, meningioencephalitis, actually a little bit rarer with this, but multi-organ failure, co-infection with Burgdorfii. Now, kind of comparing and contrasting, so we just had 3 slides that were all sort of similar, but maybe had some minute differences. So some shared characteristics of Rocky Mountain spotted fever, ehrlichiosis, and anaplasmosis, about a week incubation period, plus or minus some of the lower and upper extremes of that. All have this flu-like symptoms, the fever as well. And they all kind of present with like generalized labs with like normal white blood count, maybe a thrombocytopenia, elevated transaminases, and all 3 of them can be very deadly if not treated. But where we can see differences in our diagnosis and kind of reviewing these patients and trying to determine what we're dealing with. Rocky Mountain spotted fever is the one that's going to have almost always a rash. It was the one that was around 90%, whereas ehrlichiosis around 36%, and then anaplasmosis around 10%. And contrasting that to our previous, the Lyme disease, which was not a rickettsial disease, but was the borreliosis, the spirochete infection. That was pretty much always a rash with the erythema migrans. An interesting difference before Rocky Mountain spotted fever and ehrlichiosis anaplasmosis is this histopathologic vasculitis, and this is related to how this organism actually causes infection. So Rocky Mountain spotted fever, or the rickettsia, actually infect the vasculature, so the endothelial cells. So that's how we get these this vasculitis, or this vascular related inflammation. Whereas ehrlichiosis, anaplasmosis, these actually are going to attack some of your white blood cells. Ehrlichiosis is going to hit your monocytes, whereas anaplasmosis are going to be attacking more of your granulocytes, so your neutrophils, and those kind of polymorphonuclear cells. So that's kind of why you can see a little bit more of leukopenias or neutropenias when you have these patients, as those are the organisms, or sorry, those are the cells that are actually being actively infected within the human body. And additional differences are morulae that you can see on smear. And I believe Dr. Junkins discussed this a little bit. He kind of had a picture of a cell smear. You can kind of see these inclusion bodies. So those are usually a good marker that this patient has anaplasmosis or ehrlichiosis. Difficult to determine which one it is there. And it's also not 100% indicative, or if you go, I should say, if it's not there, it doesn't mean you don't have ehrlichiosis or anaplasmosis. It still takes a trained eye to see those morulae, as well as I mentioned the cytopenias. And additionally, for ehrlichiosis, one big difference between adults and children is the adults are going to a lot more present with this leukopenia and lymphadenopathy, whereas the children are really going to see this more of edema of the hands and feet. And I'm not going to talk a lot about laboratory testing, as Dr. Junkins discussed at great length at the previous presentation. But we did have a patient with ehrlichiosis a few weeks ago. So I thought I would just include this to give everyone, the clinicians, like what a clinician might see when someone orders this test. So this is the IgG, IgM for the rickettsia, as well as the PCRs for the ehrlichia and anaplasmosis. So you can see if you were like go in the media tab and look at a patient's report for this, you would see that this is what it might look like. So positive for ehrlichia species for the DNA. Now, treatment table, different from Lyme disease, our only option here is doxycycline. And we'll talk a little bit more in length on the next few slides for special patient scenarios. I have these durations listed here, but it's also very reasonable to treat for longer, especially for anaplasmosis and if you have an ehrlichiosis neurus, just because of the co-infections with Lyme disease that require a little bit longer treatments. Now, mentioning why we don't have any options listed besides doxycycline is because nothing else really works. We have chloramphenicol, which has activity against Rocky Mountain spotted fever, but it's ineffective against the latter two. And the CDC actually recommends against this because, well, one, we don't even have it. It's not an option in the United States anymore. It's no longer produced here, as well as it also just has higher mortality associated with it. Another one that's discussed in the literature is rifampin. It does actually have activity against ehrlichiosis and anaplasmosis, but ineffective against Lyme and Rocky Mountain spotted fever. And there's just not really enough clinical evidence to support it. We have something that works, and so we tend to focus on the doxycycline because we know it works. And the quinolones, which also the bane of our existence, not recommended for Rocky Mountain spotted fever. They have some activity if you look in the literature for ehrlichiosis, anaplasmosis, but the problem is it actually has some spotty, pun intended, spotty resistance. So depending on what quinolone you're looking at, one might be resistant, one might be susceptible, one might be, I don't even know. But there also has been cases of on-treatment resistance to anaplasmosis with it, so they're not recommended either. So really, we're looking at doxycycline as our only option. So this brings us to our special situations. So kids, I mentioned the teeth staining and the enamel hypoplasia. This is associated with, well, a class-wide, I guess, label for all the tetracyclines. And it's really just blame on tetracycline, which is based on like some 60s, data from the 60s and 70s, which showed some discoloration, a purely cosmetic discoloration, as well as well, just some discoloration, but it was all from data on tetracycline. And kind of just all the other newer tetracyclines, doxycycline got wrapped up in it. But there really wasn't any evidence on doxycycline until recently. And there's a couple studies that reviewed the incidence of this in children who were exposed to doxycycline. 2 studies, and the pooled evidence showed 0% prevalence. It just was not seen. And this is related to doxycycline it's a derivative of tetracycline, but it was constructed to be more potent. And it actually has a reduced binding for calcium, which is the reason what that tetracycline binds to teeth is the calcium. So it actually has less affinity for calcium, and that's why we see less potential teeth discoloration. This is actually why we recommend, or the American Academy of Pediatrics and the CDC recommends doxycycline for children. It's not enough to say there's no risk with doxycycline, but given the severity of the illness and the need to treat these infections, cosmetic teeth risk or discoloration risk kind of just gets thwarted by the risk of death that goes with not treating with a first-line agent. And with pregnancy and lactation, it's almost the same thing. It's data from tetracycline, but we also have this acute fatty liver risk that comes in from the maternal side. But this is actually, if you look into the data, it's just really high dose tetracycline that was given to pregnant mothers. And they developed this acute fatty liver, which has never even been seen in doxycycline. And a review of experts deemed that there was not sufficient evidence to put this blame on doxycycline, and that therapeutic doses are unlikely to pose a substantial teratogenic risk to the child as well as the mother in terms of a fatty liver. It actually warranted this FDA pregnancy team statement. You guys can read it, but essentially it's saying there's no real risk that we found with doxycycline, but we can't say there's enough evidence to say there isn't. So it's kind of, in a way, giving you the green light to use it, but and it is recommended in pregnant patients currently, but it does require a little bit more of a discussion, a joint discussion with the patient, as well as possibly OB, to discuss the risks and benefit of using doxycycline if you have a suspected rickettsial infection or Lyme disease. But generally speaking, it should be generally safe for short courses, especially doxycycline being an agent that has less binding, calcium binding for the teeth discoloration. Now for our second to last topic is severe allergy. So this is the other complicated area that we'll be touching on. So we mentioned that doxycycline is the only treatment for Rocky Mountain spotted fever, or Leosis, and Anaplasmosis. But what if we have a patient that has a severe hypersensitivity reaction, such as anaphylaxis? Very rare. Doxycycline is not really associated with anaphylaxis, but there are few case reports of this happening. And what we do for these cases are we still have to give doxycycline. There's no other way. But there's actually a few published cases of a rapid desensitization. It was actually supported by the CDC now, and it is in the guidelines. So essentially, this is a case for, or the paper originally is the Fernando Hudson paper from 2013, listed as number 22 there. But what they did was like essentially a 4-hour rapid desensitization of oral and IV, essentially, starting with oral and then progressing to IV. You can't do a PO desensitization here because the doses are so small. But essentially, these are IV pushes given every 15 minutes. There have been a couple published successes. So this paper I just referenced is one of the Q fever cases. And there's a second Q fever publication about this, as well as a case series of 10 patients with mild to moderate reactions. However, I will say this one isn't just doxycycline patients. It's tetracycline, doxycycline, as well as some tigacycline patients mixed in. But most of those weren't even anaphylactic reactions, but I included it for completeness. And for our last topic is prophylaxis. So for Lyme disease only, so this is prophylaxis for a tick bite is only indicated for Lyme disease. And what you'll do here is if you meet these criteria, you'll give a single dose of doxycycline, 200 milligrams, or if it's a child, 4.4 mg per kg, up to 200 milligrams. What you have to meet all these criteria. So geographical area of greater than 20% of the organism that causes borreliosis. Didn't translate too well on the picture here, but the yellow area obviously is the area that would count, but also some of this pale green colored would also potentially count depending on local incidence or prevalence, I should say. And if the tick was removed within 72 hours, it was engorged, and it was reliably identified as the black-leg tick, and administration can be done within 72 hours of the bite. And again, it's not indicated for anaplasmosis or Leosis. So for our key takeaways here, very different geographical differences in tick-borne illnesses in terms of what ticks are there and what organisms are present and what you need to look out for. Common theme for all of these, so Lyme disease, Rocky Mountain spotted fever, Leosis, Anaplasmosis, doxycycline is a first line treatment for all of them. And doxycycline is the only one that covers all of them. So for Lyme disease, you could use a beta-lactam, amoxicillin, or cefuroxime, but it is not going to be hitting the other 3 organisms that we discussed. Or other 3 infections that we discussed. And for our special populations, pregnancy needs a discussion with the infectious diseases provider, the patient, as well as the OB provider, and just discuss the risks. But there really is no data to, that really blames doxycycline for having any problems. But it is no contraindication to use it in this population. And if the patient is okay, it would be a strong recommendation to use the doxycycline. But you do need to talk with the patient and discuss the potential risks that are associated with doxycycline therapy. And then children less than 8, it is generally safe to give shorter courses of doxycycline. The American Academy of Pediatrics says courses less than 21 days are very safe and unlikely to cause any long-term problems. And even there's another study, I don't think I listed in this presentation, but there is a cohort of pediatric patients that received multiple courses of doxycycline, that were all of them less than 8, that did not develop, and none of them developed any teeth discoloration. And then lastly, our severe hypersensitivity reactions. How we're going to handle these are rapid desensitizations. And so with that, I will field any questions that the group has. Thank you.
Okay, just want to say thank you to Jamison for this wonderful presentation, and I'm wishing everybody a very happy and safe 4th of July. We're going to pause our Grand Round series for the week of July 4th due to the holiday, but we'll resume the following Wednesday, July 12th at 12 noon. Hope to see everybody there. Thanks so much.